Good afternoon. It's a pleasure being here. I know you have been listening to a number of fascinating presentations by a number of very, very important people. I am going to kick off this panel with a little presentation on AI, machine learning, and confluence with remote sensing and how it might be impacting the field of health and medical infrastructures. So for those of you who are not familiar with Oak Ridge National Laboratory's work for the last 20 years or so on generating global population data sets, we create a Landscan global population data at kilometer resolution, a Landscan USA, which is at 90-meter resolution, and also time variant. So you have nighttime, residential, and daytime distribution, and then we understand dynamics of how people move. Since health is entirely intertangled with people, where they are and where they move, it provides a very nice intersection with a lot of the GEOINT research and development that gets done in the community. One of the things that we are working is the extension of the US model for the rest of the world, which has provided a very important contributions from the GEOINT community over to the health and medical research community and practitioners community. So I'm going to jump in right in there. For those of you who may not recognize that this may be Nigeria, the last official census for Nigeria was done in 2006. The last official estimate was developed in 2012. And about 4 years back, I had an opportunity to intersect the Bill and Melinda Gates Foundation, their work in polio eradication from this world through some collaborators at the Center for Disease Control. They have a very simple goal, which is to vaccinate every child between 0 to 5 years old. So when your last official estimate of population was done in 2006, you are trying to find people or the section of the population that do not exist in any kind of database. And this is where I think the GEOINT research came in. So one of the ways we are trying to solve this problem is exploiting the high resolution satellite imagery that the community has been generating over the years. These are sub-meter images across the planet. And essentially, we are trying to find every human settlement that one can identify from these images. The whole workflow goes through a few different steps. But essentially, we are mapping, remapping the planet with every settlement and every building that one can see, which is a pretty amazing. And there is a large community of researchers that are involved in this area. But our work has translated into converting these things into understanding of where people are. The reason machine learning and AI is playing a big role in it is it is getting totally driven by this plethora of data sets that we have. So it provides a very fertile platform for running machine learning or deep learning convolutional neural networks that the community has been playing around with for a long, long time. I think that what GEOINT community brings to the platform for the larger community, the community at large, is the volume of data that we have to offer, and which is mostly the satellite observations across the planet. We are running these things on the large high-performance computing infrastructures that are available from the federal government and resident at Oak Ridge. And we are generating settlement maps at the resolution of 8.5 meters for a place like Addis Ababa in about 15 seconds or less, or mapping outlines of buildings, and this is one in Cameroon, at a pretty astronomical speed. I wanted to tell you a little more about why these machine learning techniques also work very well. This is an example from close from home in Albuquerque, New Mexico. And what you see in red, green, and blue are data collected from the US Census Department that shows the socioeconomic strengths or annual average income for these people. And that particular variable is expressed on the landscape in forms of how, what kind of homes do we all have. It's a rare instance globally where socioeconomically fortunate people end up living in very, very informal settlements. So there is a global scalability of this type of a model. We are exploiting the similar logic and concepts across the world where we do not have a lot of information on the ground and looking for the scalability and the scale of informality of settlements that one can observe on the landscape. And there is an example from Damascus, Syria, where you can see the formality of these buildings and residences that are sort of degenerate across the landscape from the core over to the end of the spectrum, which is at the fringes where you see the refugee and the internally displaced people living in informal settlements. These are exploited through features that are embedded in these pixels, and the machines are very good at understanding what these features are and how you can exploit these features to create the separation of the similarity. The reason we are interested in this is to understand the socioeconomic and environmental conditions of these people, where they are. And the second thing is that this is also not just a socioeconomic indicator, but it's also a resilience indicator. So if you shook the ground, let's say there is an earthquake, you can have an estimate of what is likely to be standing versus what's likely to crumble down fairly easily. These sort of novel maps are coming out based upon these these kind of research and data analysis. And here is one example from our work in several different cities across the planet. These novel GEOINT products are also opening up applications in the medical and health geography domains, because now you can understand human exposure to different kinds of environmental and anthropogenic elements as you live in a particular city. I want to quickly touch on some of the things that are interesting for understanding human activities, because people move. People are one of the few rare species on this planet who move based upon curiosity and not just based upon their need to get resources, which makes things more complicated. And if you have followed the community's work on understanding population dynamics, there are live data streams that you can, are near real-time data streams that you can look at from active sensing to understand how people might be moving around on the landscape. And then you also have model-based understanding of population movement, which will give you some futuristic projections or anticipations of movement of people at a much larger time scale. I wanted to show you a couple of examples of how this type of approach is becoming really useful. The census data at the core provides us with demographic understanding of residential population. So we know where people are, they live or sleep at night, and then their demographic breakdown, gender, age, basic socioeconomic income, education, these types of parameters. And it turns out that these kinds of variables have a very strong correlations about what kind of health profile that you might expect, what kind of access issues that you might expect for these populations to have to healthcare facilities or health infrastructure. One of the missing pieces has been to understand how these different demographic groups move around when they are not sleeping at their homes. So we have created a simulation-based understanding of these different, and here is our favorite example for Wendy, who's older than 16 years, works in the scientific waste management industry and makes certain amount of money. What we can do with this sort of synthesis, and as the more data gets, this becomes easy for a data-driven machine understanding, is where do the Wendys of the world live in a particular geography, and where do they work, and what are the likely path they're going to take as they commute between work and home, because that's essentially dictates the kinds of exposure that they're going to get, right? So I can explain this a little better by showing you this example that we had done with the National Health Assessment Facility for US EPA, where they wanted to know what kind of exposure do school kids have as they walk back and forth from home to school in the city of Philadelphia. So these data sets that was produced several years back actually ended up showing for every 5 seconds where 300,000 school kids are if they were going to be walking. It almost revolutionized the way the medical community could now understand the granularity and the fidelity of the data, and also to see what kind of exposures they will have on the street level as they are moving at a particular time when you have the rush hour traffic also standing there with emissions. So it has profound health care impacts. I'll touch on couple of last things. Everybody is interested in understanding what could you do with open source information. We have one particular effort called Planet Sense, where we are collecting 3,000 data records per second and about 2 terabytes of data a day to understand human activities across the planet for different types of infrastructure. And this is, the entire community is quite interested in how well can you use these information. So I'm going to show you one particular example which came from the GEOINT community, a simple question about if you had to put time boundaries on semantic expressions like morning, noon, or day, evening, night, when do these things start and end, right? Is it daybreak? Is it sunrise? What ended up happening is that when you do these things from a data-driven understanding, what we found out that if you can monitor over a length of period of time from open source human activities, and you can see some of these examples here. In the bottom left, you can see clearly the influence of siesta in the countries where people are clearly not active so much during the middle afternoon session. The impact of religion, climate, weather, they're all expressed through these kinds of data sets. So it's allowing us to define when people are outside and when people are inside performing different types of activities, which is also very, very important in the health sector. Landcast is a model which is trying to understand where people might be in decades from now, given the trends. This data sets that's been now put out to the entire community for use shows 2030 and 2050 distribution of US population under a business as usual scenario, projecting last 30 years of work. So in the future, what kind of, where people will go to diseases or diseases will come to people, these are important questions that can be answered from very novel GEOINT, foundational GEOINT products that the GEOINT community is sharing with the rest. So I wanted to acknowledge all the hardworking people that enable me to take credit for everything that they do. With that, I'm going to introduce our next speaker, Dr. Vince Seaman from the Bill and Melinda Gates Foundation, who I've had the fortunate opportunity to work for the last 4 years, and I showed some of the Nigeria work. So please join me in welcoming Vince.
Thank you, Bhaduri, and it was great to have him go before me because he presented most of the technical aspects of what I'm going to talk about, so I don't have to do that. I'm not really part of the GEOINT community. I actually did work for the CDC for 8 years as a field epidemiologist and spent 3 years in Nigeria before joining the foundation. But the Bill and Melinda Gates Foundation is really a global development foundation that is a family-run foundation. Bill, Melinda, his father, Bill Sr., and Warren Buffett are the management team, and every year they set a strategy for what they feel they can have the most impact in across the world in improving the lives of the most underprivileged. And this usually is in the health sector, such as vaccine preventable diseases, things like family planning, agriculture, small shareholder farmer support, access to financial services, and so forth. So we don't often work directly with all of you, although by relationships we do, and we benefited, I think, mutually by that. So I think I don't have a reverse here, but anyway, here we go. So why did we actually get into this space? In Nigeria in 2009, there was quite a large number of polio cases, and due to the efforts of WHO and other partners, that number had been reduced over the next 2 years. So by 2010, we really thought we were done with the battle to eradicate polio from Nigeria. And at that time, there were only a few other countries, India, Pakistan, and Afghanistan, that had polio, and people felt that those were manageable, but that Nigeria was really the front line for being successful in eradicating polio. And then over the next 2 years, we had a doubling in cases in 2011 and 2012. And it really was, we were at a point where people were saying that this is not going to work, you know, polio can't be eradicated, it's just too difficult. And donors were considering pulling funding, and it was a very critical time for this effort. And it's about this time that we started doing this work in Nigeria that Bhaduri mentioned. These are the kind of maps that we were working with in Nigeria, and local teams would use these maps to try and find, you know, all the local settlements so that they could go on these house-to-house campaigns over 4 days to reach all the children under 5 years old. And these maps are inaccurate, they're incomplete, they're out of date, and even though the local people seem to understand them, they don't lead to vaccinating all the children. And publicly available maps look like the one on the left. If you go to any rural area outside a large city, there's basically no features, settlement names. It's usually a major road or a large river or something is about all you'll see. But in actuality, if you extract those features, you see what's on the right. There's a lot of small settlements and hamlets and people living in these places, and those are the places we had to reach. So we embarked on this project to map the northern half of Nigeria where polio is endemic. And so the first part of that process was obtaining high-resolution satellite imagery, and we worked with the Oak Ridge team to extract the settlement features, and we did some aggregation to make it easier to map. We then sent field teams to every settlement in the north, so over 100,000 settlements in northern Nigeria, and they collected the name, location, and specific points of interest that were important to the program. So these included health facilities, markets, schools, places of worship, and others. And then we were, part of the settlement name collection, we also collected the administrative attribute so that we could then create boundaries around groups of settlements that belong to the same administrative area. And these didn't exist at the ward level in Nigeria, and that's the level where we implement these campaigns, so that was important to do. So we went from having a map like the one on the left with basically no detail, nothing really to support any kind of activity, to the one on the right, which has a lot of detail and was actually successful in helping us eliminate polio from most of the north. So this shows we went from, we were missing about 4% of the settlements in campaigns before we started this project, and by the time we were finished, we were virtually down to 0. You've seen this map on the upper right. So we also recognized at the time that the denominator was a big problem in Nigeria, so understanding how many people we should be vaccinating was important to know, because we could count how many people we did vaccinate, and so in order to get an understanding of our coverage, we needed this data. So we partnered with the Oak Ridge team and a group called Flowminder, who makes a product called WorldPop, and they're spatial demographers. And we embarked on this project to try and do bottom-up population modeling. So we started with the same layer, so we already had that, the settlement layer. The Oak Ridge team then classified the urban areas and rural areas into neighborhood types. So these are based on line patterns and really give you a poverty map of an area. And I think this has a lot of other uses besides modeling population, and Bhaduri mentioned a few of those. We then sent field teams to do micro-census counts in a selection of each type of these neighborhoods across the whole country, and ended up with a 90-meter gridded surface with a population number inside each box. And then we could toggle that using survey data. We can model the demographic fractions for each of those boxes, so we could either get total population or under 5, under 1, or so forth. And then we created a user interface that was simple for local people to use. This is just a close-up of the neighborhood typologies, and on the right is an urban area in northern Nigeria in the state of Kano. And you can see each type of neighborhood and where it exists. And this has really a lot of implications, especially for the slum areas, which are a big problem in a lot of developing countries, trying to figure out the extent of those. Are they growing or shrinking? And if we need to provide services, making sure we're doing that. This is just a close-up of the output, and we're 100% sure where we have zeros. Where we have other numbers, there's less certainty, but we are working on generating 95% confidence intervals for those estimates, so at least we know where we're at. This is just a summary of the data for the country. Actually, the estimates for this model are very close to the projected census population estimates. And even though we know the census was not all that great when it was done, and the growth rates that were applied over the years are, they're greater in urban areas and less in rural areas, the numbers for the whole country seem to stack up, and we feel that that actually supports the validity of this model, because we know at a country level the birth and death rates of countries fairly closely, so at that level at least it's somewhat accurate. We have all of this data on a site called Geopod. It's geopod.world, and the data for Nigeria, and we have also similar data for the Lake Chad region, which we're doing an outbreak response in, is available. So you can go there and either view the data or download it in various formats. And this includes every settlement, a name on most of them, boundaries that we validated, and the population gridded surface layer. And these are just the different actions you can take when you get there. So we learned a few key lessons during this project, besides helping us reach all these children. And I'm going to go through them quickly. Number one, most countries use a flat percentage for each demographic that they're interested in. So in Nigeria, for the under 5 population, they use 20% of the total population, and no matter where you are in the country. However, we used survey data that is extensively collected in these countries, the Demographic and Health Survey, or DHS survey, that collects household size and all the demographic information in the household. And we actually found that the under 5 percentage ranges from 11% in the south to 23% in the north. So if you're in the south and you're using 20%, you're almost going to come up with double the number of children that you really have. And this is important if you have an expensive vaccine or you're trying to calculate coverage. and you're using an incorrect denominator. We also found that the growth is occurring in the urban areas and in different parts of the urban areas. So this is another shot of this Kano metropolitan area. And you can see the yellow building footprints are from 2014, and the dark green were 2006. So most of the growth has been around the edges of this urban area. And on the right, it shows the administrative areas, and the growth rates range there from about 1% to 8% a year. So if you think about applying a 3% growth rate to all of these each year for 10 years, when instead the growth rates are between 1 and maybe 8 or 9%, you end up with census projections that are way off for these subnational levels. We also found that the boundary shapefiles that these countries have are incorrect. Imprecise maybe is the best term. And it's not that they don't know where the boundaries are, they just don't have the right spatial representation. And this didn't matter when we were just using maps to color different colors for different rates and things. But now that we have geospatial data coming in, we need to have correct boundaries if we're going to do spatial analysis for things like population and disease rates. So this is a huge problem, and it has to be done pretty much on the ground. You can't do this unless there's a river or a main road that you know is the boundary for a place. Most of it has to be collected on the ground. And here's just an example of the population difference. The boundary on the left, VTS is the vaccination tracking system, which is the polio data collection effort. And that's the true boundary based on our ground-based information. And the population of this area is about almost 700,000 people, where the boundary on the right is the one that the government publishes as the official boundary. And the population estimate for that shape is about 480,000. So it's really important to use the boundary that is correct. And finally, using this neighborhood classification map, we got some household survey data. So all the major surveys that are done to collect health and demographic data use a census enumeration area maps to identify clusters. And then they go to the clusters and select a few households in each cluster. And we overlaid a set of households that were sampled for one of these major surveys, and we found that none of the houses fell into type A, which are the slums, and none of them fell into type F, which is the wealthy neighborhoods. And this is not surprising because neither of these areas are very well serviced when they do a census. So this could be a huge problem because we may not be really getting representative data from these surveys that everybody uses for health and demographic information. So a few applications quickly. The other things that we've used this data for. President Ghani in Afghanistan wanted to get a sense of the population in that country. The last census in Afghanistan is 1979. So you can imagine they have no clue really how many people are in some parts of that country that have been inaccessible. So due to the time constraints, the Oak Ridge team was working on the feature extraction and settlement segmentation, but we had to move ahead quickly because there was a time limit on it. And this shows the variance in what the population could be since 1979 if you just had a 0.5% difference in the growth rate. And it's about plus or minus 20 million today. So we had data for the dark green areas that the government had been able to collect census enumeration data over the last few years. And then using spatial covariate layers such as distance to a main road, nighttime lights, elevation, and so forth that correlate fairly strongly with population, we're able to model the population for the rest of the country. And so the output is a population layer at the EA enumeration area level that we then disaggregated to a 100-meter surface. And then the confidence intervals are on the right. I'll just go by this. And this made a difference in the under 5 population. The program was using 10 million people, and there's actually only maybe 6 million. So we know that we're losing vaccine somewhere. We use the polio setup in Nigeria, all the smartphones and the infrastructure and training that people had to help respond to the Ebola outbreak in Lagos. And we were able to track over 1,000 primary contacts within the first week. And I think it helped avoid a major continuation of that outbreak. And I just have a couple more. We used DEM, I think it's the 15-meter aster maps to model the catchment areas for environmental surveillance. So we collect water from sewage or wastewater sites to detect poliovirus and other enteric diseases. And using, we have maps for about 17 countries, but we are able to predict from a collection site at the top, we can predict the catchment area for that site. So we know that if something shows up in that site, it came from this particular shaded area, and we can target an intervention. And this was just a fixed post or intravenous vaccination campaign where we know people won't travel more than 1 kilometer to get a service. So we were able to automate a tool to cluster all the settlements within 1 kilometer of each other. And then we would put a fixed post in each one of those. And we can use the population modeling tool to then understand how many children are in that area and estimate the need for vaccine and supplies. We used aggregated tracks for the tracking system that we did for vaccinators to look at roads and transportation network. And the last thing is we are combining with CDC to do an imagery change analysis in northeastern Nigeria. A lot of those settlements have been destroyed, and we need to know that because we're trying to send teams out to vaccinate children. The World Food Program's trying to get food to people, and we don't want to send people out to places that no longer exist. So we've been comparing imagery from 2013 to more recent imagery and then reclassifying settlements. And all the red X's you see in the upper right-hand corner are settlements that are no longer there. So over 70% of the settlements in the 2 upper admin areas are gone. And these are just maps showing our vaccination reach in that area. So I'm over time, but I'd like to just end on, we have a project to produce this data in other countries. It's called Grid 3, and we're finishing up Nigeria. We'll be trying to work in Ethiopia, DRC, Tanzania, and Zambia this year, and add additional countries as we go forward. Thank you. Oh, and I'm introducing our next speaker, Mario Schootman.
Good afternoon. Recognizing that I stand between you and the open bar and the happy hour, I'll try to make this relatively a quick presentation. I don't really have to tell you that GIS consists of several data layers, but this is really no different in public health either, where several additional layers consist of, for example, a disease layer, as you can see on this slide, potentially a genetics layer, landscape layer, behavioral layer, and things like that. Very interesting that lots of government agencies and organizations are very interested in thinking about how context affects health, disease, health outcomes from a geospatial type of perspective. But so how do we really go about measuring neighborhoods in public health? Lots of different ways by which we can do that. For example, we can look at census tract poverty rate. We can look at the location of local businesses, where are parks located, grocery stores, but we also can actually ask individuals, what do you think of your environment? Are you feeling safe in that environment? How stressful do you think your environment is? And so forth. We can also look at the census data, poverty rate, for example, but also Google Street View and Google Earth that we can look at to see where individuals live, what characteristics are of those neighborhoods, and how they potentially interact with disease development. Most studies, though, have focused on residential neighborhood characteristics. For example, they've looked at concentrated disadvantage, percentage of poverty rate, for example, and the idea that environment influences behavior is well established, But until very recently, the data and tools necessary to investigate this in public health in a thorough and systematic way were really not available. But now GIS, as you're well aware, has really come of age. So most research in public health has focused in the past on looking at residential location. So where do individuals live prior, directly prior, or at the time of diagnosis? But we really realized that most of the, or a lot of the exposure of individuals in public health as we move through the environment and as we live our lives are really not at the time of that location, at that point in time, as well as that particular location. Often we use residential boundaries or administrative boundaries such as counties or census tracts and so forth. Well, there's really not a wall around those characteristics. And so we have to go beyond those types of aspects of the built environment, the environment, to really see how that affects disease outcome. So how can we use emerging technology to measure neighborhood conditions as they relate to behavior and disease? And one aspect I'm going to talk about is Google Street View. So how can we move beyond the residential neighborhood to measure what goes on in the environment, what goes on in the social, but especially the built environment? And here you can see some examples by which Google Street View is collecting data. Some of them, Google is mapping the entire planet, and so some include some more exotic locations as well. To look at that Google Street View, the way that then is portrayed in this still image, in this static image of this 360-degree image. This is the building, this is St. Louis University. And so we can look and see what kind of characteristics there are in that particular environment. A little bit more close to home, some of the things that we see in our area. Can Google Street View, for example, capture conditions like this? Can we quantify that? Can we quantify conditions like this where the street is really buckled up, not very conducive to walking, not very conducive especially to wheelchair use, for example? So can we look at the validity and reliability of Google Street View compared to when you go out and actually observe the neighborhood? And so what we did was we sampled over 300 street segments and compared the Google Street View data to when individuals went out and observed those same type of street segments and those same conditions using Google Street View. And we sampled by racial distribution in the top right, top left, bottom right, and bottom left corner. We sampled by racial distribution and block group poverty characteristics from each of those four corners of this 3x3 table. And what we found was that if you look at this graph, kappa of 0.8 means near perfect agreement between Google Street View and when somebody actually observed and goes out and observed that neighborhood. And so a kappa of 0.8 means near perfect agreement, which means that Google Street View can actually capture and accurately capture those conditions that we see actually on the ground. So how can we then marry Google Street View with individuals as they move about their daily lives, as they move about their environment? So ecological momentary assessment uses mobile devices to collect data on emotional, social, biological, and behavioral states, and also activities as they occur, as individuals move through their environment, through space and time. And we can obviously combine that with GPS technology to see where those behaviors, where that exposure that predisposes individuals to become diseased actually does occur. And we can collect that using mobile phones, and we can then ask individuals at particular points in time, for example, what are your mood states? Are you being physically active? Are you smoking? Are you drinking alcohol? And so forth, but also their psychological states. We can take it one step further, and now you may think, well, this is the presenter. Well, I have to disappoint you. This is not me. But there are sensors in this particular shirt, and so can we then marry the Google Street View with the ecological momentary assessment, as well as with sensors in that shirt that measure EKG, heart rate, breathing rate, and activity levels to get a better sense of the exposure by which individuals are moving about through their daily lives. So in summary, can we connect the physical world with the virtual world as we go about our daily lives? So for example, geo-referenced tweets and other social media correspond to particular locations and are influenced by each user's individual perception of that particular space. So Twitter data can potentially serve as contextual information and an indicator of how strongly the physical and the virtual world are connected to each other. But we have to realize the limitations of Twitter as well, and those tweets, only 15% are geo-referenced, and some of those are geo-referenced to the world and not necessarily to a particular latitude and longitude. So can we think through ways by which we measure exposure as you and I move through the environment, as we move through daily life, as we are exposed to different aspects of that particular environment? And in the past, like I said, most studies in epidemiology and public health and clinical medicine have really focused on occupational or residential exposures at the time that a particular diagnosis occurs. But we have to think more broadly and think of more and new directions tracking participants through their individual environment. And so using mobile phones, using Google Street View, this new technology allows for the connection of the exposure of individuals as they move through the environment with potentially disease or behavioral types of outcomes. And this all becomes now technologically possible. So in the past, there has been lots of focus on ecological momentary assessment, EMA, so simply assessing and monitoring individuals as they move through their environment. But is there now an opportunity to really look at intervening as well as a function of a particular location? So can mobile devices also be used to intervene? So for example, GPS technology tracks the patients when they approach a particular area where they traditionally obtained or consumed alcohol, a particular alcohol outlet, and so they can receive just-in-time intervention at that particular moment, at that particular location, to potentially support getting through that high-risk situation and not, for example, taking that particular alcohol or not buying it or not smoking as a function of local triggers in that individual's characteristics as part of their environment. So we can avoid high-risk relapses, avoid high-risk situations as well. And so can this method, for example, also be used to reduce location-based triggers, to reduce symptoms of PTSD? And one example has been the CDC. Here's some studies that simply looked at the assessment, and some of them are looking at the intervention as well. And the CDC has looked at how can we use calls to a local 211 line for flu-related symptoms. Can we map those characteristics of that environment and tell individuals what is going on in their particular neighborhood, in their particular high-risk situations, and can we then avoid those exposures as well? So what we know now is that neighborhood conditions play an important role in the risk of various disease outcomes, including infectious diseases, but also chronic diseases such as cancer, heart disease, and so forth. Next steps, the way I see it, include real-time monitoring of individuals, but also focusing on interventions and try to see how we can reduce exposure as a function of when and where individuals are in their daily lives. Thank you.
All right, thank you, gentlemen. I've got a couple of questions here to start the discussion, so I'm getting a little bit of echo here. I will put these out for you, and then we can have a discussion. Which part of the medical community is the most invested? Okay, I'm sorry. Which part of the medical community is the most invested or at the forefront of geospatial data use? I'll start with you here.
That's a good question. I think the public health aspect in terms of the medical relationship, I think there's a real sense of that GIS and GI science has really come of age over the last 10 years. And as a function, there's a lot more focus on social determinants of health, such as local poverty rates, racial distributions, and so forth.
Okay.
Yeah, I mean, I agree with that, although I think that right now at least, it's pretty fragmented, and I don't know that we're at like the cutting edge of technology. I mean, like most of the work I showed is pretty basic stuff, but it's data that we have to have before we can do the other things. I do think the private sector, I'm sure Big Pharma uses a lot of, of this kind of stuff, and I also know that the clinical trials area is starting to do a lot of big data, crunching to help better design their studies and reduce their costs.
So one can think about this investment from the medical community in few different ways. I think if you think domestically, the National Cancer Institute or the National Institutes of Health have had long-standing investments in collecting geographic data on diseases and mortalities and incidences. So there are maps, they are atlases of cancer mortality, so for a long time. So in terms of risk analysis of diseases, that community has shown novel uses of geographic data for a long time. I think that there's been quite a bit of investments in there. I think Mario touched on something where the medical community is truly a pioneer. At the same time, there are quite a bit of gaps. The space-time trail, a space-time trajectory is an important aspect of the data sets that the medical community probably has the most access to. I think what we quite haven't figured out is how to best take advantage of the investment that they have made in collecting that type of data, including cancer risk and circadian clocks. As we travel around across time zones, what does that do to our health, which is essentially embedded in sort of data collected by the medical community. I applaud Mario's comment. I think the opportunity that they show us is, you and I, anybody in this room, when we go into a doctor's office, the first thing you get to do is fill out a pretty impressive number of pieces of paper and forms, and it asks you about everything, including your family history, but never your space-time history. It's as long as you have one address where you live and they can call you or send you a bill, that's all they need from you, which is pretty startling. So maybe there is a cross walk from things that we are doing into that work.
Excellent insight. I hadn't thought of that, but that's a good point. Yes, please.
And I think as CMS, for example, is really focusing, I mean, obviously, it's a big payer and a big driver of the healthcare market. And I think as more and more CMS realizes that neighborhood matters, geography matters, I think things will be more and more incorporated and required of physicians' offices and health systems to be incorporated into electronic medical records, is when the adoption will become even more throughout and more pervasive.
Okay. All right, if there's no more comments on that question.
Well, I would just
please.
make one last comment,
Yeah.
and I think that one of the areas that there's a lot of interest in, and it's been touched on a little bit throughout the day, is the global health security. Okay. And the pandemic preparedness and so forth. And there is a huge opportunity there, and people are looking to see what we can do.
Okay, thank you. All right, the next question we have is, what medical or health problems should the geospatial industry be partnering with the medical industry to try to solve? And if there are multiple areas, is there a priority of those areas that you see? So start again here with you.
I think there's a real opportunity for data visualization and spatial statistics. One of the presenters earlier today looked and described various components of individuals as they move through time and space and capturing those characteristics at the same time. I think that's very innovative, and thinking about how we can then quantify that as part of data science and spatial statistics, I think that will be very important. I think the connection between spatial and spatio-temporal types of statistics and not making only making maps. Maps are very, very important, but thinking how we can go beyond maps and try to get more inferences about disease occurrence, where care occurs, where exposure occurs, and how we can then try to intervene and improve care and health overall.
Yeah, I would say identifying and mapping risk, probably. I think we haven't used the spatial tools that are now becoming available to do that. CDC does a lot of that, but telling people, like if you live in a certain part of the country or world, you might be more at risk for something, and there are certain things you can do to mitigate that. And we know that's important, especially with all the environmental issues we have around now.
So there are two areas I think we can look at working with that community for a priority identification. I think looking inwards domestically, we are engaged in an effort with the VA that's looking at the Million Veterans data set. That is a very, very high priority objective that, can you drive the outcome from 22 veterans committing suicide every day, and how far down can you take that number by looking at all the data that is been collected, including the inefficiency that in the system of scheduling, that a lot of people fail to show up for their appointments, and you have to wait for a long time. So your attention to those people, and which is again part of the resource allocation, and how do you use that approach spatially is key. On the other aspect, I think all the people who are doing research in genetics and genomics, they're hitting a very priority area about understanding historical movement of people, and by, let's say, I've seen examples of where trying to understand historical dispersions from mapping languages over landscapes, which is a key understanding and priority area that I don't think the community has made a very good progress.
Okay. Any follow-up comments from anybody else? Okay. Just a reminder, if you've got any questions, don't hesitate to write them down, send them up to the front. I do have one question, kind of a personal question. So as you gentlemen may have heard, if you've been here throughout the day, AI, ML, automation has been a big theme within the remarks that have been made and the presentations that have been made today. And it's just a theme within the intelligence community, the DoD community. How do you see, again, AI, ML, automation impacting the medical community?
I think in terms of the mobile device and tracking people over time, some studies now have looked at identifying those participants and say, well, this is a high-risk area for me. But instead, can ML, machine learning, can that identify those particular areas? People are, to a certain extent, unreliable. It's self-report. So can those mobile devices use machine learning to identify, well, these are the areas where individuals have particular problems in terms of buying alcohol, consuming alcohol, smoking, or some psychosocial types of signs and symptoms of PTSD or other types of psychological issues. So can machine learning use the data that individuals are providing themselves through those mobile devices to identify those areas and then provide triggers to reduce that exposure and reduce that disease and health outcome.
Yeah, I forgot to mention this, but because IBM is a sponsor today, my director back at the foundation is a guy named Uwe Stewart, who is recently from IBM, 15 plus years there. And he worked on the Watson project, and he's an AI ML guy. And he, after about 6 months, told me that he realizes that, you know, in most of the places we work, that those kinds of solutions are a little bit down the road, because we don't even have the basic reference data to you know, make even the most basic calculations or analyses. And it's part of this global South, you know, issue is that in the developing world, there's just a really lack of almost all the kinds of data that we have access to here. And you know, they don't have the smartphone penetration, they don't have the networks. A lot of people are not online, so it's really a blank slate in a lot of these places. And until we get you know, at least the basic reference data for those places down, it's going to be hard for us to apply those types of solutions in those areas.
I'll just mention one, I think, interesting aspect of where we can share some of these AI principles. I think, you know, there is a lot of concerns when it comes to understanding the privacy implications associated with geographic data around individuals. And as we grow our the universe of, you know, sort of wearable technologies and the individual level data sets that's going to be coming from measuring our biometrics all the time, you know, which is key to our space-time trail. There is some level of comfort on having machines handle and analyze those data instead of, you know, direct human intervention. So there is a level of comfort, and I think we should potentially look at AI machine learning in bypassing that privacy concerns in terms of delivering outcomes.
Okay. I think we've got time for about one more question here, and you actually had a pretty good lead into this next question here. So this one comes from the audience. Combining Twitter, Google, smartphone applications, maybe on your watch or on your phone, whatever that may be, and other data sources connected with users' health raises data privacy concerns. What steps will help us maintain privacy while still making the technological advances necessary to better serve the healthcare community?
Wow, that's a big question.
It is.
And not an easy one either. I think we probably will have to look at expanding the capabilities of handling data and to have data brokers to where lots of data will be able to come in to be able to analyze that in a certain way so that confidentiality is protected as much as possible. I think, you know, as researchers, we deal with these things all the time. So I think there are some systems in place already, but I think as we get more and more invasive and try to think through ways by which we can capture individuals as they move through their environment, probably new ways of masking geographic data in space as well in time should be really thought of.
Yeah, I mean, it's really an important question, and I think that we are in a place right now where we're operating without a license, so to speak. I mean, because we haven't established this data governance or the rules for this, and if we don't do it, if the geospatial community doesn't do it, the politicians will do it for us. So I think it's something that needs to be addressed, and you know, I don't think you can avoid some loss of personal privacy. The more data is available, pretty much people can start predicting where people will be and who would have done the crime, you know, like the 1984 situation. But we can put in place maybe anonymization algorithms and ways to, you know, make the data as less intrusive as possible.
So I'll add one thing to everything that Mario and Vince has said. One common misconception that we deal with is that privacy is not a global standard. If you go to the global south, the expectations of privacy is quite different from the ones that we are used to here. I want to give you one example and maybe make one appeal just to stimulate the thought process about how privacy could be changed in this world of AI. The AI machine learning, deep learning is essentially going to be only successful when we have a lot of data that is allowing us to generate knowledge by machines churning through it. If you remember a few years back, the US Census Bureau opened up a very, very detailed data set on US population for the section of the population who are non-existent. They are all died, so for dead people. So there was no privacy concern there. So, so I've been thinking about, where does this take us as a society? If you think about any decisions we make, whether it's in health or any other infrastructure, it is still largely based upon the survey instrument, which tries to replicate a normal distributions of the population. So you are essentially sampling a fraction of the entire population, maybe 10, 20, 30, 40% at best. So on my driver's license, I have a choice to check the box whether I want to be an organ donor. I do not have a choice if I want to be a data donor. So if I collect all my biometrics with wearable technologies, and the next generation does, what are rights or pathways where we can become data donors that can allow machines or artificial intelligence to really work well? So I think that's an opportunity for us.
Excellent. Well, thank you. All three of you have given us some very interesting things to think about. Unfortunately, we're out of time for further questions, so please, big round of applause for these gentlemen here. We really appreciate it.